Hello and welcome to another podcast. Today we're going to continue with our specific pharmacology and we're going to look at glyceryl trinitrate, or as the Americans like to call it, nitroglycerin. Indications are you can definitely use it for cardiac related chest pain and it's perfectly designed for angina pectoris. We can also use it for similar reasons to improve oxygenation and reduce preload for acute pulmonary edema. Can be effective in Irukandji syndrome in the presence of hypertension, and in the case of acute hypertensive crisis, it's based on a medical officer's order only. So anyone who's been looking at GTN, and you all should be pretty familiar with the drug, you may have heard around the traps the dangers associated with giving GTN for anyone that has an inferior myocardial infarct. So the clinical significance of an inferior infarct is the fact that it could be a right ventricular infarct. In fact, 40% of all cases that have inferior involvement can in fact be a right ventricular infarct, and that complicates things. So patients with a right ventricular infarcts are very, very sensitive to preload problems. Okay, and it can develop into severe hypertension. So a lot of organisations out there have actually made GTN and other nitrates completely contraindicated for anyone that has a right-sided infarct. Now, our PCCM doesn't specify it, however, it is good to know of the potential, so then you can look for things, and if you believe it could be right ventricular involvement, meaning you have an inferior MI, then it's best to call the MO and go off the advice instead of going along with GTN. So how do we find a right ventricular infarct? First step is you need to do a 12-lead ECG. Everyone who has chest pain should get a 12-lead ECG anyway, and then we look for specific clinical findings. Now the big ones you can look for is ST elevation in lead 3 and lead 2. So as you can see, the area that is highlighted in red is lead 3, lead 2, and AVF as well. Those three leads denote an inferior infarct. Now, in order to increase the probability of it being a right ventricular infarct, you need to look at the infliction of lead 3 versus lead 2. And if lead 3 is larger than lead 2, then it denotes more likely to be a right ventricular. The reason for this is lead 3 is more rightward facing than lead 2, hence it is more sensitive to injury and can produce a right ventricular infarct. Other tips are you can look for ST elevation in V1 and reciprocal changes in ST depression in V2, but we can also look in our AVL for reciprocal changes of ST depression as well. If you see these signs, a right ventricular infarct is confirmed by the presence of ST elevation in the right-sided leads. So, if you have the chance, do a complete right-sided ECG, but if you don't, if you're time sensitive, you can't quite remember, the most useful lead to use is V4R, so putting V4 on the right side. And that is simply done by placing the V4 electrode in the 5th intercostal space on the right side mid-clavicular line. Now the V4R has a sensitivity of about 88% and a specificity of 78% in diagnostic accuracy for a right-sided MI. Okay, so it's a really good one to use. And if you see these particular ones, like I said, manage the patient, fluids are good, calling the doctor, evacuation, and report your findings before giving any GTN. Now to have a look at GTN in its specifics, we'll just have a look at a little bit of pharmacokinetics. So pharmacokinetics for GTN are pretty interesting. It's a very rapid drug. It has an onset of 1 to 3 minutes, hence why we give it every 5 minutes, but its clinical effects can last up to 30 minutes. Its distribution bioavailability is excessively low. Okay, realistically, 38.5% bioavailability in the target areas is quite low for a drug, hence the need to give more doses. The good news is it is bound to protein up to 60% of the load. Okay, that means it is going to have that lasting background, which usually means that subsequent doses are going to be more effective if the first one didn't work. Now, the reason for its low bioavailability is because once it enters the bloodstream, it's instantly degraded by the liver before it goes to its vascular wall. Now, the vascular wall is actually where the action takes place. Okay, but the degraded GTN is shared between the vascular wall and the red blood cells for further metabolization. So, the target organ has a 38.5% bioavailability within the vascular wall. After that, it's eliminated in the urine, and it has a half-life of about 1 to 4 minutes. So what does it do specifically? Well, GTN is a vasodilator, and in natural speak, it's what's known as an organic nitrate, which causes systemic vasodilation and decreases preload. So its cellular mechanism works because it enters the vascular smooth muscle and is converted to nitrous oxide. Now, nitrous oxide is very, very good at inducing synthesis of an enzyme known as cGMP, and that causes vasodilation. The vasodilation goes on to decrease both preload and afterload, and this is where the relief and the problem comes from, depending on which side of the heart we're referring to. So if we go back and look at right ventricular failure, the right ventricle is under very low afterload pressure because it only goes to the lungs. So unless the person has pulmonary hypertension, the right side doesn't need to work very hard in order to push the blood out. So it relies on the Frank-Stahl's law of preload in order to generate the small amount of force it needs to get to the lungs. If the preload is reduced, then it's not going to have the strength in order to feed the lungs, and it's going to cause a flow-on effect, the blood coming back to the left ventricle, which is going to cause an effect on the cardiac output. In turn, will lower the blood pressure to dangerous levels, which compounds the preload. So for right-sided, because it is very preload sensitive, GTN can be a contraindication. Whereas the left side, the large muscular size of the heart, if it is working hard against a massive afterload, or it is receiving a lot of blood resulting in a large preload, it results in a large amount of muscular tissue needing to be utilized in order to generate the force required to maintain cardiac output. By reducing the afterload and preload, what actually happens is you reduce the overall myocardial requirements of oxygen and nutrient supply. Therefore, the muscle works less. When the muscle works less, it doesn't build up harmful toxins, and it's able to last longer, pretty much like any other muscle in your body. On top of this, depending on the doses, once we start getting to the higher doses, we actually get a dilation of the coronary arteries themselves, and that feeds more oxygen and nutrients to the heart. Now, it's very important to note that the coronary arteries are actually filled by the remaining pressure after systole has been achieved. So it's actually the diastole pressure that feeds the coronary arteries, and that needs to be maintained at a certain level in order to provide supply to the heart itself. If you would like more information on the heart, and in particular afterload and preload, then you can check the link above and have a look at the overall pathophysiology of the cardiovascular system. But in the interest of time for this particular video, we'll move on and we'll keep talking about GTN itself. Now, there's a few warnings associated with GTN. Now, the main ones are is before you give GTN, you have to make sure that they don't actually have an allergy to it. And a big one is you need to make sure that they're not hypertensive. But like I said, diastole plays a big role in it as well. Okay, so don't forget and maybe have a look at the map instead. But I'll let you do your own research in that in order to get a better understanding. One of the other contraindications is anyone that's been put on a PDE5 inhibitor within the last 24 to 48 hours, depending on the drug itself. Okay, the adverse effects to GTN can be varied and many, but the main one that you'll find is actually headaches and flushing of the face. Some of the more dangerous ones includes hypertension, as discussed, and also the feeling of heart palpitations as well. Okay, other drugs that we need to be aware of that people are taking before giving GTN is your ergot alkalines. Now, these particular drugs cause vasoconstriction. It's actually an antagonist to GTN, so GTN doesn't work. Now, these particular drugs are used to treat migraines and things like uterine bleeds, that sort of thing. So they are quite rare. Now, the PDE5 inhibitors stands for your phosphodiesterase 5 inhibitors. Now, these are vasodilators, okay, and there's pretty much 4 drugs that fall into those ones. That is your sildenafils, also known as Viagra, tadalafils, vardenafils, and avanafils. So they're the main ones. Now, because these particular ones also work on the cGMP enzyme in order to cause vasodilation, they have a synergistic effect with GTN and actually profound vasodilatory effects. So just to remind you all, if you give low dose GTN, you often get arterial dilation, which affects the preload. And it's not until you move up to the higher doses that you will start getting that arterial dilation and a decrease in peripheral resistance. And also that's when the coronary artery dilation kicks in as well. And that's when you'll have effects of preload and afterload and a greater drop within the blood pressure. Now, when you mix them with PDE5 inhibitors, you automatically go to the high dose end, despite how much you are giving, which increases the risk of hypertension. Okay, we'll finish off with a few clinical take-homes. The patients that we're treating with GTN generally have a problem with cardiac output or hypertension itself, so it's always advisable to obtain IV and an absolute pinch IO access before administering GTN. Okay, now that's ideal. However, you can give the first dose whilst you're getting IV access, things like that. Just play it by ear. But if you're getting one and someone is already a little bit hypertensive with these chest pains, then put 2 in. Okay, it's always better to have 2. Always recommended that you start low and only move up to those higher doses if somebody suffers from angina and therefore has a greater tolerance. Now, tolerance generally develops for personnel that are taking GTN regularly, so between 2 to 3 times a week. So if you have a patient like that, you can generally move up to the higher doses, but it's still recommended to start at 400, check for clinical effects, and then move up. Now, if for some crazy reason you are using the tablets, you need to inform the patient that they're not to swallow the tablets. If you swallow the tablet, it does not have the same bioavailability, and it's pretty much rendered useless. Now, if you're utilizing the spray, because it can get clogged up pretty easily, it's always recommended to spray a few times away from the patient, away from anyone else's skin, until you get a good spray, and then administer it under the tongue. Now, be careful. GTN is absorbed through the skin and will actually reach its target organ through the skin as well. Okay, so if it accidentally gets on the patient's skin, it needs to be taken into account as an accumulative dose, because you can get adverse effects. Also, if you get some older hands telling you that GTN is a great thing to spray on the skin in order to cause localized vasodilation, improve cannulation, it's not advisable. Okay, it is absorbed by the skin and it will have the overall effects on preload and afterload that you'll get as if you sprayed it underneath the tongue. Okay, so that ends this lesson on GTN, glyceryl trinitrate. I hope you got something out of it. Now, if you want to revisit GTN, in particular its use in acute coronary syndrome, then you can click on the link above and it'll take you to a presentation that is all about acute coronary syndrome, an in-depth analysis, if you will, of all the treatments for acute coronary syndrome. And until next time, take care.